Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Now, my dear students and fellows and colleagues and the practicing physicians and those who are appearing in the examinations like MCPS or FCPS internal medicine or FCPS in the infectious diseases. Now today I'm talking to you something about brucellosis. I am Professor S. Ali Haider and I am Global Senior Visiting Professor. I am Honorary Visiting Professor of Medicine without any fame, without any economics. Just to increase my knowledge and your knowledge. This is my aim actually. Spread the knowledge. Although the people are not taking interest in the sessions, which I have actually recorded about 225 videos in my channel, and that channel is what is called as the clinical lectures, clinical medical lectures. Although the students and the other doctors, they are not interested. They are not taking interest. One thing reminding you about this, that if you will not study in this session and you forget it about it, that is not important. Not important is not important, and is very important rather, I will say, in medicine is concerned. Because sometimes the most least diagnosis will be the diagnosis. The first question of mine is actually is that I am actually taking a serial of lectures of a very, very big chapter of infectious diseases. The question of mine is how much cases you have seen of this condition, brucellosis, in your life. So I have, done about 46 years of clinical medicine practice, and I have seen about 6 to 7 cases of brucellosis, which I have come across. And these cases are, one of the cases was presented also in the Dow Medical College, Arag Auditorium. Otherwise, this means that this disease is a rare disease. It is not seen commonly. Second point is that these are the gram-negative bacteria which I am discussing. And one thing is more is that this disease is a zoonotic disease. The zoonotic disease are the diseases which can spread via animal kingdom. Not animal, but animal kingdom. Whether they are vectors or whether they are mammals or whatever they are. If they are spreading from the animal kingdom to the humans, the condition is known as brucellosis. Conditions are called as the zoonotic diseases. Zoonotic disease. So it is a zoonotic disease. Maybe it is spread by the animal kingdom. These cases are missing cases usually. You miss these cases. Usually because you don't think about it. You are not keeping the case under your differential diagnosis at all. So that's why I am talking about this disease, brucellosis. Let's talk something about the brucellosis. Now, it is an infectious disease caused by the bacteria. It is a gram-negative bacteria. People can get the disease when they are in contact with the infected animals or the animal products, derivatives of the animals, contaminated with the bacteria, this genus, Brucellosis, Brucella. The animals that are most commonly infected, they include are sheep, goats, cattle, any cattle, pigs, dogs, and there are many other cattle families and other animals, even carnivorous animals other than the dogs. Wolves, for example, they can be spread like this. It is not noted that they are spread by the birds, not commonly. It is not seen. It is not reported that those animals who are actually whether herbivorous or carnivorous, and they are found in the forests or in the areas of the villages where they keep these animals as pets for their purposes. The source of infection is the highly contagious disease. It is a zoonosis. It is caused usually by, not always, by the ingestion of the unpasteurized milk or undercooked meat from the infected animals. So veterinary surgeons should check for it before they are passing the animal, butchered animal, to their market. They are called the food inspectors. They are experts, and they are veterinary. They are veterinary doctors or surgeons, and they have got responsibility to check and pass the meat to the market. In our country, you know that because of there are the doctors, even the nurses, and I'm sorry to say that the other paramedics on the related health care providers, they are not doing duties punctually and honestly. That's why this disease can be the cause of unknown fever, paroxysm of unknown origin, or it can be the source of infection because of the secretions which are coming out from these animals. One is the unpasteurized milk, another one urine. The secretions are coming like, for example, the saliva. Now, another name of the fever, there are three more name of the fever. It is called undulant fever because the fever is in undulation. Undulant fever is a remittent fever. Second is the Malta fever because in the Malta is the region where it is mostly found, and there are a lot of the herbivorous animals, especially speaking about the cows, and their export of their milk is much higher. They export the milk to the other countries. Malta fever. And in the Mediterranean zone, because they are very, very rich in grass and greeneries, and a lot of foods are available for the animals, especially cattle, this disease can be spread and can be contacted in the Mediterranean zone, where we find this that start from the Syria and from Iraq to the Lebanon and coming to that side. Again, the what's called as the Germany and the France and even Switzerland can contact. It is possibility that the contacts are more. Now this is the spread of the brucellosis. Now these names are based on the infected animals. If it is spreading from the pigs, it is caused by one of the species of the Brucella, which is called the Brucellosis. Caused by the Brucellosis, and it is got the highest pathogenicity. from the pigs. From the dogs, it is called the Brucellosis canis. It's got the moderate pathogenicity. From the cattle, it is Brucellosis abortus. Moderate pathogenicity causes abortion in cows, not in animals. It is only animals, not in humans is concerned. Sheep, and there is another species which is called the Brucellosis melitensis, starting from the sheep, is high pathogenicity. And this is a disease which I have seen actually from the person who have migrated from the Afghanistan to the Pakistan. So all 7 cases are reported, all diagnosed, all came to me for the assessment are Brucellosis melitensis. Only one case I have seen about Brucellosis abortus, and I have not seen anything Brucellosis canis or Swiss. There are 4 species. The first one and the last one, they are highly pathogenic. Canis and abortus have got moderate type of pathogenicity. But the disease is problematical because it will cause the paroxysm of unknown invasion. Secondly, I will say one point more, that it is very difficult to differentiate this disease from the enteric fever, that is typhoid fever. It's difficult, it's not easy. Both diseases are very similar. Both are gram-negative, both are got the same type of the pathogenic processes, that is coming from the transient bacteremia to the bacteremia, then going for the septicemia and pyemia and SIRS. So these are the same type of the process going on in the enteric fever. But for both diseases are very, very similar in the presentation. If you ask in the history, when you are asking actually what is called socio-economical condition and the profession, you can have an idea that this paroxysm of invasion can be because of the brucella. Now this is the spread, that is brucellosis. It is spread in this fashion which I said about bacteremia, through milk, through raw dairy products. Many dairy products are available, and direct contact like butchers and farmers. Profession is important therefore. And the meat processing industries are there in this country also, and the veterinary doctors and paramedics and those who are involving in the labs, especially the veterinary labs, they have got the highest indemnity. Now, clinical microbiology, there the bacteria causing the disease is Brucella. They are small gram-negative, non-motile, non-sporing forming, rod-shaped Coccobacilli bacteria. They function as facultative intracellular parasites. They use oxygenation very, very small amount, causing the chronic disease. This disease can become chronic. In enteric fever, there is no chronic enteric fever. There is possibility of the recurrence of the typhoid fever, but there is nothing like chronic type of typhoid fever. Because the natural history of the disease of the enteric fever is different than the natural history of the brucella. And then it persists for the life because it is the intracellular species. For life, that is why it is persists for the life. If you will not manage this case. 4 species, in fact, the humans, I already said the canines, from the carnivorous animals like dogs, melitensis, sheep and Swiss from the pigs, and abortus from the cattle. Now these are the one, that is, except the Swiss is concerned and Maltensis is concerned, the Canis and abortus are less virulent. Then Maltensis is a primary disease of the cattle, actually. Now, Brucellosis canis affects the dogs, but Maltensis is the most virulent and invasive species. I have said that. It usually infects goats and occasionally sheep. Swiss is of the intermediate virulence and chiefly infect the pigs. Pigs are usually not eaten in our country. But there is possibility that in some part of your country they are using the pigs also. So beacon may be the source. The symptoms include the profuse sweating and joint and muscle pain. It is non-specific, the presentation. Brucellosis has been recognized in animals and humans since the early 20th century. Before that, this disease was labeled as the idiopathic PUO. They don't know the cause, exactly what is the cause. In low power microfield, it is just like this, a web-like appearance. The gram-negative bacilli. In high power field, you see it is cocobacillus. It's slender, and they combined and form the impression of the cocobacilli. Interestingly, the incidence in Pakistan animals, this is the journal which I have contacted, is this, that the brucella is considered endemic in Pakistan. Endemic. Although it is not diagnosed by many of us, and has been reported in domestic ruminants, cattle, buffaloes, sheep and goats, and camels, and it may be non-ruminants, for example, the equines and the dogs. So these are the carnivorous animals. They are also present in your country. Wildlife and human are in contact. The brucellosis causes the economic losses to the farmers in Pakistan because the animals die usually because of the brucella. It is spreading like a wildfire in the cattle zone, and a lot of cattle will be killed if the disease is spreading. There will be fetal losses also in an animal husbandry, and there will be infertility, reduced milk production, prolonged calving intervals, and losses due to the culling of the animals. Now, to our knowledge, the information concerning economic losses related to the brucellosis in Pakistan is not available. But in the United States, it is about 3.4 billion loss for the dairy cattle, and about 58 million for the active surveillance programs in India. So India is much higher losses are there. In Pakistan, we don't know, it may be possibility of 1.2 to 1.5 million dollars in Pakistan is concerned. In America it is billion, and in India it is, in our zone it is much higher, 58.8. In humans is concerned, to our best knowledge in Pakistan, because they have done this research in around the Peshawar area, that is Khyber Pakhtunkhwa. The first human brucellosis study was reported in 1979 in Pakistan, and it was approved in 1979. My admission of medical college is 1974-75. So I don't know about that. I have seen this case in 1979. I actually have got chance to see or to diagnose, follow up these cases after, you can say, 1988 to 1997-98. Currently, it has been reported that among all provinces, the highest number of patients were from the Punjab. Because a lot of cattle, the area is big, is about 5.8 to 10%, roughly, at the hospital, outdoor and 6.87 to 38.94 in occupationally exposed. Those are related with these milk products and the dairy products, or butchers. And KPK it is 2 to 36.4%. So it is very, very high rate in KPK, especially at the Afghan camps. It's still considered highly underreported. I say that it is underreported because you are not able for the diagnosis. And the misdiagnosed cases, they are labeled as enteric fever. Brucellosis generally presents as undulate fever or chronic malaise. Human patients without abortion or arthritis are treated for the general febrile malaise, and brucellosis is suspected when patients do not respond to the routine treatments. So it is the diagnosis of exclusion in most cases. It means that the patients are often serologically positive and negative, PCR or culture, if these two approaches are performed. It may be possibility of the false positive and false negative in these cases. Delays in the onset of the appropriate treatment often cause more severe and chronic disease symptoms with cardiac, intestinal, nervous, pulmonary complications. Same as enteric fever, or those bacteria who are going in the path of the bacteremia, septicemia, pyemia. The antimicrobials most frequently used to treat the human brucellosis are tetracyclines, aminoglycosides, and fluoroquinolones. Both brucella abortus and malsensis have been confirmed by PCR in human patients. So far, no isolate has been reported from the humans. Isolation means cultured positively. It is estimated that the occupational exposure, especially among veterinarians and the farmers, and the raw milk intake are the greatest risk. This is the greatest risk in this, especially among these professions. All humans are dead and hosts. The presence of brucellosis in the humans indicates a disease burden in animals. Thus, controlling the disease in animals is the most economic approach to address the brucellosis in humans. If the cow, for example, is near death, you butchered out and it become halal, and then they sell it out. Buffaloes, if they are, in the end of their life, they are butchered and become halal, and they sell it out in the market, and that is why the humans are infected in this fashion. Cities are involved. Despite the government initiatives, knowledge of the farmers and the risk of the brucellosis to date remains low in rural areas, because they do not use it, the animals who are dead because of the brucellosis. They send to the cities where a lot of money have been given. And another important point which I want to tell you, that especially talking about the beef. The beef is actually now is cost effective in Pakistan because they are all smuggled to the Afghanistan. Most of it, I will say 70%, these people are very fond of to take beef items in Afghanistan. So they are more involved as the disease process is concerned, rather than in Pakistan. The source of infection is in Pakistan, but the disease process is going in Afghanistan. This is my way of judgment. The clinical feature is the same one. You see that if you study the enteric fever, same one is here. The symptoms are like those associated with any other febrile illnesses, with emphasis on myalgia, night sweats. The myalgia and night sweat mean that it may be tuberculosis. The duration of the disease can vary from the few weeks to many months, or many months to even years. Chronicity, look the chronicity of the disease. In the first stage of the disease, the bacteremia occurs and leads to the classical triad of undulant fever, that is, indulation of the fever, remittent fever, sweating often with the characteristic foul, moldy smells, sometimes likened to wet hay. ये सड़ जाता है जो गंदम जो होता है जो रखते हैं जो बाहर पानी में भीग जाता है या ओस में भीग जाता है उसमें से स्मेल आती है उस टाइप की स्मेल होती है इनके स्वेट में. And the migratory arthralgia and myalgia. So it is one of the cause of arthralgia, not arthritis. Migratory arthralgia and myalgia. Joint and the muscle pain and blood tests characteristically reveal a low number of the white cells, leukopenia, and maybe possibility of anemia, and show some elevation of the liver enzymes such as AST and ALT, and demonstrated positive Bangor-Rose test and Huddleston reactions. These are the tests which are for the isolation purposes. Usually not done. They are doing actually serology nowadays. The gastrointestinal symptoms occur in 70% of the cases and include the nausea and vomiting, decreased appetite, unintentional weight loss, abdominal pain, constipation, diarrhea, enlarged liver inflammation, hepatitis, that is, it can cause abscess of the liver and it can cause the enlargement of the spleen, that is, splenomegaly. This complex is at least in Portugal, Israel, Syria, and Jordan. In this area, they are called Malta fever. And during the episode of the Malta fever, the melitococcemia, presence of the brucella in the blood in these countries, it is called melitococcemia, can usually be demonstrated by means of the blood culture in diptose medium of Albany medium. Specific media they are using, because a specific type of the species are present in that country, probably of the Brucellosis, for example, which is not seen in Pakistan. If untreated, the disease can give origin to focalizations to some area and become chronic. And these focalizations of brucellosis occur usually in unexpected places like bones and inside the joint. Osteomyelitis and spondylodiscitis of the lumbar spine accompanied by the sacroiliitis. The sacroiliitis occurs, if it is sacroiliitis in a young person, and it will be definitely differentially diagnosed from one condition also, that is ankylosing spondylitis. It is very characteristic of this disease. Back pain association with paroxysms of unknown origin with splenomegaly. Chances of brucella will be there. Now, Kata is also common in men, which is not seen in the enteric fever. And then the consequences of the brucellosis infection are highly variable and may include arthritis, spondylitis. It may cause thrombocytopenia, meningitis, uveitis, optic neuritis, endocarditis. So every organ is involved. Multi-organ dysfunction syndrome can occur if it is not treated on the time of the diagnosis is delayed. If you are delaying the diagnosis, it means that you are involving these systems and the various neurological disorders. And collectively, this condition is known as neurobrucellosis. These are the manifestations in one slide. That is, starting this influenza-like fever with reaching to 38 to 40 degree, limb back pains, sweating, fatigue, already mentioned, non-specific anorexia, weakness, severe fatigue, backache, specifically the backache is important, headache, leukocyte count tend to be normal, or it may be reduced, just like in enteric fever. And there is relative lymphocytosis, which is also seen in enteric fever. Relative leukopenia is possible as enteric fever. Thrombocytopenia is also a part of the enteric fever. It is also seen in brucellosis. On physical examination, the splenomegaly may be the only finding. This is very important. Again, in the enteric fever, the first organ which can be the physical sign in abdomen is splenomegaly. So you have got skills to diagnose the enlargement of the spleen. I will take one class only for this, how to detect the splenomegaly. And kind of interest लेने की बात है. If you are taking interest in the medicine, the people are involved to learn, and they put questions. I'm there, I'm here, I will face the questions, and you can understand it. The best way to study it in a groups. The patient is there in the ward, and that is called the PBL, the problem-based learning. That you can remember the disease for many years. Anyway, now this is the pattern which is seen. It is a remittent type of the fever, undulation, up down, and mostly it is remittent fever rather than intermittent fever. The undulation. Look the chart here. Another condition which is seen, the part of it is the neurobrucellosis. The symptoms of the neurobrucellosis could be mild. I have seen one case in my life. And non-specific and classical triad of meningitis are uncommon. Although I am expecting meningitis. But here it is another one that is encephalitis is more commonly seen. Mild CSF pleocytosis means WBC are seen in the CSF. Fewer than 50 leukocytes per microliter of CSF was common, but severe hyperproteinuria means protein levels are higher in the CSF, and severe hypoglycemia means that the glucose levels are down, just like in any infection of the meningitis. Typically seen also in neurobrucellosis. That's all right. If this is a meningitis, negligibility, Carnegie signs, Brudensky signs are positive, then it is fine. Otherwise, the other way of presentation is different. That is the functional problems of the brain. Patient may be presented with you as in the case of depression. Maybe I've seen one case told by my colleague, he was a psychiatrist, that it was turned out to be, he was diagnosed by him as schizophrenic. But at the time when he was diagnosing, he had contacted with another physician, and he diagnosed this case as neurobrucellosis. So organic disease, it is organic disease which he was treating for the schizophrenia. So in anxiety and the depression, and you can see in this condition even the panic disorder can occur. But in the case of the enteric fever is concerned, it is not chronic first of all. So this enteric fever can cause the meningitis, it can cause encephalitis. Yes, but these type of symptoms are not seen in enteric fever. Now here you can localize abscesses are seen. This is the ring forming lesion here. This one. It may be you will see at one time the differential diagnosis of this ring enhancing MRI lesions. We will discuss later on. The diagnosis of brucellosis relies on the titration of the agent. The blood cultures in tryptose broth bone marrow cultures, the growth of the brucella is extremely slow. It can take up to 2 months to grow. 2 months. And the culture poses a risk to the lab personnel to the high infectivity of the brucella. Just like coronavirus, you have to take steps where you are diagnosing and culturing it or for going for serology. Now, demonstration of antibodies against the agent either with the classical Hansen, Wright, and the Bengal rose reactions can be demonstrated by the antibodies, either with ELISA or the 2 Markov up to ethanol assay of IgM antibodies. So I am expecting IgM antibodies in this case. You go write it down, ELISA for the brucella or brucellin test. So IgM antibodies associated with the chronic disease. IgG are also seen. It means that it will see the chronicity. It will show the chronicity of the disease. The histological evidence of the granulomatous hepatitis on hepatic biopsy, it is difficult to do it. So it is one of the causes of the granulomatous hepatitis. The radiological alteration in infected vertebrae, X-ray plane lumbosacral spine will show you the Pedro-Pons sign, that is the preferential erosion of the anterior superior corner of the lumbar vertebrae, where see the erosions are seen, and that is called the Pedro-Pons sign. And the marked osteophyte are suspicious of the brucellic spondylitis, that is the inflammation of the vertebrae. They may be, diagnostic, one of the important diagnostic criteria of this. Now this is the Brucellosis gel test. Seropositivity detected to GN177. It is a very sensitive index. The titer is shown here, 174, 175, 176, etc. You see the low titer, it is positive, rather than the high titer. So it becomes positive in this test, that is the Brucellosis gel test. Those people who are appearing in the FCPS examination, they must tell this test to the examiner that it can be done and you can diagnose from it. The differential diagnosis are of specifically, I will only speak about because disease is very close to the enteric fever. Forget about the infective endocarditis, miliary, Hodgkin lymphoma, infectious mononucleosis. Only thing the typhoid and the animal brucellosis. The onset in the typhoid is 1 week. In brucellosis, it is gradual onset. So it is this, the ESR is increasing, and again the brucellosis is increasing, very similar. Leukocyte count, leukopenia, maybe possibility normal count, in enteric as well as in brucellosis. Lymphocyte counts, relative lymphocytosis are seen in enteric fever as well as in brucellosis. Look the similarity of the disease. I'm sorry that I am poor in handling the computer. The toxic changes of the neutrophils are seen increasing in. This is not seen in brucellosis. Toxic changes in the neutrophils, that is the lobulation and the other, endoplazmic reticulum and the mitochondria in the high power microscope are increasing. You see increment in the toxic changes. But in case of the brucellosis, it is not seen, although it is intracellular type of parasite. Eosinophilia almost eosinophil count are absent, very low or absent. It is not, it means zero count. But in brucellosis, it is decreased, but not zero. So you can differentiate, this is a differentiating point between these two. Blood cultures are positive in the first week. It is rarely positive in the brucellosis in the early phase of the disease. Rarely positive. and this is the gold standard of the diagnosis. Here it is not gold standard of the diagnosis in brucellosis. The means of diagnosis here is the blood culture, the gold standard. But the means of diagnosis in brucellosis is serology or blood culture in some cases. You have to go for the brucellin test or ELISA for the IgM. That is the way to diagnose it. Or you go for the, if you are you have got facility to do the liver biopsy, you can prove the granulomatous hepatitis, and you can find the brucella intracellular in the hepatocytes. You can demonstrate it, but it is difficult to do. This is wrong Rose Bengal plate test. They are using in countries like in India and in Burma and along this one. So blood is, and the serum is taken for the ELISA. This is ELISA, and here increment are seen, slide by slide. Increment are seen as the about the titer is concerned. Rose Bengal is added in the serum, and it will show the increment of the area involved, which is seen in this plate. Diagnosis is made, I have already said, by it is direct evidence by the blood culture. You can go for what is called the bone biopsy, bone marrow biopsy, and liver biopsy, direct evidence. Another way of diagnosing, you can do the Rose Bengal test for the agglutination test are possibilities. Nowadays, we are diagnosing on the basis of the clinical diagnosis, plus we have to prove the M immunoglobulins in the ELISA. Although there is cross reactivity between the Vibrio cholera and Salmonella with this test. So there may be false positive test, there may be false negative test. False negative tests are there because of the proton phenomena, because the blocking antibodies. It is called proton phenomena. That is why it becomes the false negative. There is no way to diagnose it means that. Your clinical judgment is important. दिमाग मानना पड़ेगा इसमें आप। और रिलायबल आप जो लैब पे हो जाते हैं तो फिर वो फॉल्स पॉजिटिव फॉल्स नेगेटिव का मसला आ जाता है, सेंसिटिविटी का, सेलेक्टिविटी का, स्पेसिफिसिटी का मसला आ जाएगा। फिर अदर टेस्ट इसमें बहुत सारे और उन्होंने बनाए थे, जैसे मैंने पहले आपको बताया, उन्होंने अपनी अपनी कंट्री में बनाए हुए हैं डायग्नोसिस के लिए। PCR अगर कर सकते हैं आप सीक्रेशंस की, अब वहाँ प्रूव कर सकते हैं इसको एज ए डायरेक्ट एविडेंस, मगर इट इज डिफिकल्ट वन, बिकॉज ये कि इवन जो है ना वो सक्सेसफुल ट्रीटमेंट इट बिकम्स पॉजिटिव ऑलवेज, जस्ट लाइक इन कोरोना ऑलरेडी, कि कोरोना जो है वो ख़त्म हो चुका, अब फिर जो किसी को नज़ला वज़ला हुआ दोबारा कराया तो फिर कोरोना पॉजिटिव आ गया। तो कोरोना का परसिस्टेंसी है, इसी तरह से इसकी भी परसिस्टेंसी है, तो कैरियर स्टेज में है ये, इसका मतलब ये हुआ। पेशेंट बिल्कुल नॉर्मल है, इसको कोई प्रॉब्लम नहीं है। अलबत्ता क्रॉनिक ब्रूसेलोसिस जिसकी बात की थी वो न्यूरो ब्रूसेलोसिस है बेसिकली। उसके अंदर अब आपको जो है ना सीएनएस के सिम्टम मिलेंगे, परसिस्टेंट जो है ना आपको लिकोपीनिया मिलेगा इसमें और लिम्फोसाइटोसिस मिलेगा। तो इसको आप कर सकते हैं डायग्नोसिस इनकी हेल्प से, ये हेल्पिंग हैंड्स टूल्स हैं, मगर ये कि गोल्ड स्टैंडर्ड नहीं है इनमें से कोई भी, सिवाय आप ये कहेंगे एलाइजा से प्रूव कर दें आप स्पेसिफिकली, वो भी यहाँ अवेलेबल इतना नहीं है पाकिस्तान में। सिर्फ जो AQH लैब में है, कुछ और लैब्स हैं, अभी चौथाई लैब्स वगैरह हैं पाकिस्तान में, उन्होंने इसकी किट्स मंगाई हैं क्योंकि उनको अब पता चला है कि यहाँ पे भी ये डिजीज़ हो सकती है। देखें अब ये हो सकती है, उनके ध्यान में भी नहीं है ये बात। आखिरी चीज़ जो आपको बतानी है वो मैनेजमेंट है इसका। आपके पास जो टूल्स हैं इसके लिए फार्माकोलॉजिकल, वो टेट्रासाइक्लिन है, रिफेम्पिसिन है, अमाइनो ग्लाइकोसाइड लाइक स्ट्रेप्टोमाइसिन, जेंटामाइसिन है। अब 3 ड्रग हैं, अब क्यूनोलोन्स भी इसमें शामिल किए गए हैं। अब इसका जो है कि ये भी बिल्कुल ट्यूबरकुलोसिस की तरह ट्रीट की जाती है। ये मोनोथेरेपी कभी भी नहीं देते इसमें। 2 एंटीबायोटिक या 3 एंटीबायोटिक ट्रिपल रिजीम देंगे या ड्यूअल रिजीम देंगे, इसमें कभी भी नहीं देते। जबकि एंटारिफी में आप मोनोथेरेपी कर सकते हैं। गोल्ड स्टैंडर्ड क्या है इसका? इंट्रामस्कुलर इंजेक्शन स्ट्रेप्टोमाइसिन 1 ग्राम फॉर 14 डेज विद ओरल डॉक्साइक्लिन 100 मिलीग्राम ट्वाइस अ डे। वो तो बंद कर दें आप 14 दिन के बाद स्ट्रेप्टोमाइसिन, मगर डॉक्साइक्लिन को 45 डेज जारी रहेगी और हो सकता है इससे भी ज़्यादा देनी पड़े। जेंटामाइसिन इसके अगर फर्स्ट को पेशेंट यंग है और द चांसेस ऑफ द स्ट्रेप्टोमाइसिन कैन कॉज द डेफनेस, तो यू कैन सब्सटीट्यूट जेंटामाइसिन। कुछ जगहों पर जो है ना इन्हें मिला, खासतौर पर चिल्ड्रन के अंदर जो है डॉक्साइक्लिन विद रिफेम्पिसिन और कोटामैक्सोजोल ट्रिपल थेरेपी में ये सक्सेसफुल रहा है। स्पेसिफिकली स्पीकिंग इन केसेस ऑफ न्यूरोब्रोसिलोसिस, what doxycycline again 100 milligram twice a day, rifampicin 450 milligram, and cotrimoxazole 500 milligram. BD, it is OD, it is BD, it is BD. Successfully to treat the neuroblastoma. इसके अलावा जो है ना डॉक्साइक्लिन प्लस स्ट्रेप्टोमाइसिन regime is more effective than doxycycline plus rifampicin regime for 6 weeks. तो अगर एक्यूट थेरेपी किसी को देनी है तो 3 वीक्स के लिए डॉक्साइक्लिन को स्ट्रेप्टोमाइसिन के साथ मिला दें, इंजेक्टेबल है, एक ओरल है। दूसरी जो थेरेपी है इफेक्टिव लेकिन 6 वीक्स की नहीं होती है, वो एक्यूट अगर कंडीशन है तो डॉक्साइक्लिन को रिफेम्पिसिन के साथ मिला दें। डॉक्साइक्लिन जो है ना ब्लड ब्रेन बैरियर को ईजिली क्रॉस करती है, इट ईजी क्रॉसेस इट, but it requires the other 2 agents to prevent the relapse. They are using nowadays ciprofloxacin and cotrimoxazole subtron therapy associated with the unacceptably high rate of relapse. लेकिन बहरहाल कहने का ये इसके साथ आपको मिलाना है किसी चीज़ को, और ये वर्क करें। इससे अगर रिलैप्स रेट ज़्यादा होता है तो फिर आप रिफेम्पिसिन को मिला दें या फिर इंजेक्टेबल को मिलाएं। पर यानी कैसे इंडोकार्डाइटिस कैन अकर विद ब्रूसेला एंड इट गॉट दी, अगर ये हो गया एक दफ़ा तो ये क्रॉनिक हो जाता है। प्रॉब्लम ये है, वैल्व्स आर इन्वॉल्व्ड, तो यू हैव टू डू द सर्जरी फॉर द ऑप्टिमल आउटकम, अदरवाइज ये रिलैप्स होगा बार बार और पेशेंट जो है ना मोर्टेलिटी बढ़ जाएगी। प्रिवेंशन इसको आपको करना पड़ेगा, आपके लिए ज़्यादा आपको सर्वेलेंस करना पड़ेगा, पेशेंट की सर्वेलॉजी करानी पड़ेगी, उस एरिया की कुछ ले लेंगे जोन और उस पर स्टडी करें। खासतौर पे जो है ना एनिमल किंगडम के अंदर इस पर वर्क करना चाहिए और वैक्सीनेशन प्रोग्राम्स होने चाहिए, उनके हाइजीनिक प्रोग्राम्स होने चाहिए। ये गाय भैंसें आपने देखा होगा कि ये चल रही होती हैं, कराची की बात कर रहा हूँ, ये गटर के पास जो थैलियाँ पड़ी हैं वो भी खा जाती हैं वो। अब ऐसी सूरत में यहाँ से मिल्क आप हासिल कर रहे हैं, चांसेस ऑफ ब्रूसेला तो होगा यहाँ पे। इतनी अनहाइजीनिक वे में उनको आप पैसे बचाने के लिए छोड़ दिया आपने उठा के, वो थैलियाँ खा रही हैं, उसमें पता नहीं क्या क्या भरा हुआ होता है। तो इसलिए जो है वो कराची में भी ये हो सकता है, लोग मिस कर जाते हैं, ये मिसिंग डायग्नोसिस है। हाइजीन जो है ना रॉ मिल्क प्रोडक्ट्स के अंदर जो है प्रिवेंटिंग, इसमें ये पास्चराइजेशन अगर आप करेंगे, पास्चराइजेशन का मतलब ये होता है कि मिल्क को 101 डिग्री बॉइलिंग पॉइंट पे लाने के बाद छोड़ दिया जाता है फॉर 5 to 10 मिनट्स और फिर ठंडा किया जाता है इसको, ये पास्चराइजेशन कहलाती है। और इसके डेरिवेटिव चीज़ बनाते हैं, मलाई और बहुत सारी चीज़ें बनाते हैं, तो वो आप पहले पास्चराइज करें मिल्क को, फिर ये बनाएं। प्रोनोसिस इसकी जो है ना वो जो है ना वो क्रॉनिक डिजीज अगर हो गई किसी को, खास तौर पे अगर इसको हार्ट इन्वॉल्व हो गया, एंडोकार्डाइटिस, तो पुअर है इसकी आउटकम अच्छा नहीं है इसका। अदरवाइज यू हैव टू गो टू सर्जरी और इन्फेक्टेड वाल्व शुड बी रिमूव्ड। ये एक तो पॉसिबिलिटी है। वो जगह जहाँ पे वैक्सीनेशन प्रोग्राम है वहाँ पे प्रोग्नोसिस अच्छी है, जहाँ वैक्सीनेशन प्रोग्राम नहीं है वहाँ पे इसकी प्रोग्नोसिस पुअर है। दूसरा मसला है इसकी क्रॉनिसिटी, क्रॉनिक इन्फेक्शन है वैसे एक्यूट इन्फ्लेमेशन, लेकिन ये क्रॉनिक हो जाता है बिकॉज ये डायग्नोसिस ही नहीं कर पाएंगे तो फिर क्या करेंगे आप। मैंने जो है लोगों को ट्रीट किया 3 मंथ से 6 मंथ तक, मुसलसल सारे अफगानिस्तान के थे और कामयाबी से ट्रीट किया। तो मैंने जो दिया इन लोगों को जो वो चले जाते हैं यहाँ से, तो शुरू में तो मैंने स्ट्रेप्टोमाइसिन को रिफेम्पिसिन के साथ इस्तेमाल किया है, डॉक्सीसाइक्लिन को मैंने ट्रिपल रिजिम डायरेक्ट दे दिए। फिर मैंने लिवर फंक्शन टेस्ट करा के भी चेक कर लिया। ये हमने दी इस थेरेपी को 15 डेज, और बाद में हमने ALT अगर नॉर्मल आ रहा है, इसका कोई इतनी ज़्यादा हायर नहीं है, तो रिफेम्पिसिन को हमने ऐड कर देंगे डॉक्सीसाइक्लिन के साथ, रिफेम्पिसिन को, और उसको मुसलसल दिए उन पेशेंट को 6 मंथ्स मज़ीद। तब जाके ये पेशेंट जो आउट हुआ है, बीमारी से निकला है। तो वो आते रहते थे पहले मेरे पास। आई एम वेरी थैंकफुल दैट यू हैव लिसन दिस लेक्चर, ऑल्दो I don't know it is useful or not. Wama ilana illal bala. Assalamu alaikum wa rahmatullahi wa barakatuh.